Okay,
Okay,
good.
welcome everybody. Good evening. And I am Lauren Dudek. I'm our Senior VP at Lumisk, home of CO2 Lift. And this evening, I had the pleasure of introducing Dr. Gustavo Levashoff.
Hello, how
So,
are you?
Dr. Levashoff is a world-leading cosmetic gynecologist and educator, the president of the International Union of Lipoplasty and ICAM USA, and he has shaped aesthetic medicine over the past 35 years with innovation, research, and global training, and also the grandfather of carboxy. So you've been using injectable carboxy therapy for 30 some years and then
Mhm.
now have been using the transdermal gel and just wrapped up an amazing study, and we are going to allow him and are very honored to have him here to present your data. So I will go ahead and go ahead and let you take it away here, Dr. Libashoff. Thanks so much.
Thank you. The honor is for me. I'm very happy to are all with you. I am Dr. Gustavo Leivasov. You will listen very special English. My English is I am from Argentina, so please don't cry for me. But I have a special English. I think you will understand what I say because really it's very important. I work in phlebology also during many, many years. I am OBGYN, but I work in phlebology during 25 years in Argentina. I am member of the Society of Phlebology, and ulcers for me is something very important. And let me tell you, I will tell you why ulcer is important and why this study really was surprise to us because we make this study and we don't know what happened. It's a flip coin. We don't know. And well, you will see the results now. When I talk about the learning to increase our knowledge, we seek something speed, efficient, cost, and quality. We need to find all of this to find a good improve of our knowledge to apply in the treatment of our patients. And if we talk about the varicose ulcers, we need to start to talking about the chronic venous insufficiency. This is the syndrome to affecting the veins in the legs. Remember, there are no many animals, we are animals, to have varicose vein. So the bipedestation, our price for the varicose vein. There are some dogs or another horse to have the possibility to have something like varicose vein. But basically, we, the human being, the Homo sapiens, we have veins because our bipedestation. So it's our price for walk. And in the start, we have some symptoms, but if they continue the disease, we have pain, swelling, skin damage, and ulcer. And we look all these steps now, and you understand why the treatment working well. And don't forget, there are some factors to help development the insufficient. For example, use these strong trousers in our legs, for example, use a bad skin, but make some ligaments in your legs. High tile, not good because this articulation here is our second heart. And this is when you have a high tile, this is not working. And don't work in our leisure plant, and working over the lymphatic system. And also the hormones and also the alteration in the static also help to have the insufficiency, the chronic insufficiency. And we have a classification you can see here. You can see also in the videos after that and the symptoms, and you will see how this classification we use in the evolution of the treatment of our patients later on. This chronic venous insufficiency or chronic venous insufficiency affect the lower limbs and happen to the valvular incompetence, venous obstructions, or post-thrombotic phenomenon. The most common is the valvular incompetence. It's not a life-threatening disease, but it's a long-standing morbidity with financial and social consequence. And when you have a wound, you need a good tissue perfusion and oxygenation. And when you have some delaying of the oxygenation, you have delay in the perfusion, more the oxygenation, you have a patient with the chronic venous insufficiency, and you have an ulcers with the time. like this. Also, the chronic venous insufficiency have an alteration in the microcirculation. All the alteration in the big circulation start in the microcirculation, and this produce the exchange and the ulcer formation. So we need to know, you will see very soon, how the tissue oxygenation can be predicted, and we can evaluation to the transcutaneous partial oxygen pressure, we evaluation the amount of oxygen and the possibility to recover this skin from the ulcers. I put all the reference in the bottom in yellow color for your information if you want to know more. So the patient who have a severe chronic venous insufficiency have hyperpigmentation, lipodermatosclerosis, and the ulcers. And why happen these ulcers and lipodermatosclerosis? Because we have irregular fibroblastic activity, excessive scar tissue formation, and we have a development of excessive matrix contraction. Normally, we have the extracellular matrix. The extracellular matrix must be fluid, a balanced fluid to allow to exchange of the molecules for all the cells. If you produce more procollagen 1, for example, you don't produce metalloproteinasas, you produce an excessive matrix contraction, and this produces an alteration in the tissue, and there are a retraction and a vicious scars. And the other things is the normal fibroblast. Normally, when you have a normal fibroblast and you want to your normal fibroblast produce procollagen with the stimulation of transforming ground factor beta to add in the platelets. Well, in the ulcers, in the venous ulcers, the fibroblasts in the venous ulcer don't have the possibility to produce collagen. I don't want to say collagen, is procollagen the right word, because these fibroblasts don't working well, and we look very soon what happened with these fibroblasts. So we have an inflammatory injury. So we have vascular, we have less oxygen, you have inflammatory injury to damage the skin and the dermis. We have a microcirculatory venous hypertension. This hypertension in the microcirculation produces that the macromolecules and the red blood cells go outside of the microcirculation, go to the tissue, go to the matrix. And also we have excessive iron deposition in the dermal intertissue. You understand? It's all a disaster. Also, the red cell degradation produce iron from the hemoglobin, and we have interstitial protein extravasation, and all produce a great inflammatory reaction. So we have a chronic inflammatory signal there. So it's a very big problem. So we have inflammation. We need something to make all the cake. Oh yes, the leukocyte. The leukocyte arrive to the inflammation, and the leukocyte produce the destruction of the extracellular matrix dermal, destruction of the architecture, and the formation of the venous ulcer. And we have a large amount, and this is the strawberry in the cake. We have the pro-inflammatory cytokines like interleukin 1, interleukin 1A, 1B, interferon G, interleukin 12. All of these produce a great inflammatory reaction in the ulcers. So as you can see, we have a big problem to make the treatment of this patient. Also, we have the venous hypertension. When the valves in the legs are affected, all the system have valves because we walk, and we live against the gravity, okay? When the people have aging in the skin, but also have changed because the gravity, and we need to work against the gravity sometimes possible. And in the legs, we have more gravity, and these valves, there are V valves, is dilated, and the blood go in the wrong direction. It's the retrograde blood flow, and increase the venous hypertension, so increase the pressure, more fluid and proteins go outside, edema in our patients with more hemosiderin deposition and pigmentation, and disturbance of the endothelial cells and their glycocalyx coating. So there are emargination and activation of the white cells, more inflammation, more oxidative stress. So we have more multiple cytokines and chemokines. And also we have more metalloproteinasas to destroy, like metalloproteinasa 14, for example, to destroy the fibulin, is a protein in the skin, for example. And all of this produce the ulcer. And more, we have something more, the pericapillary fibrin cuff, to don't allow to the growth factors of the oxygen go to the area of the ulcers. So we have more epoxy in the area, more ulcers. And you can see this evolution or explanation of the ulcer is dramatical. And fibroblasts, normal fibroblasts produce is the factory of our pre-collagen, pro-collagen, post-collagen, collagen. But in this disease, fibroblasts is very damaged, so there are poor wound healing and there are dermal fibrosis. There are not a replication of the fibroblasts. The venous hypertension produce something called fibroblast development myofibroblast phenotype. And myofibroblasts produce fibrosis. And produces fibrosis is a scar reaction. And there are more problematic also arrive the leukocyte again, more inflammation, more difficult to wound healing, more iron, more hemosiderin. Is a retroalimentation all the time, a bad feedback for the skin. Remember, when you make a treatment of the patient, it's a patient with a wound, not only the wound itself. I explain this because the patient to have a wound is a special patient, is a patient to suffer a lot, feel very bad, and we need to make a contention of this patient. And this patient is a patient to make many treatments, and sometimes the treatment to close the wound fail, heal long enough, and he developed a chronic disease. Normally, when start all of this, if you remember the 4 typical phases of wound healing, hemostasia, inflammation, proliferation, and remodeling, the alteration, the wound starts in the inflammatory phase. You can see different kind of ulcers, venous, arterial, neuropathic, of pressure, different kind of ulcer that we have. We talk about only today about the varicose venous ulcers. Also, it's very important, remember the veins are in the dermis white adipose tissue, in the subcutaneous white adipose tissue. And normally, these adipose tissue are very inflammatory, increase the size, are more metalloproteinasas, decrease the fibulin, decrease the elastin fibers. There are a large amount of mu cells, this blue here. This is related with pro-inflammatory reaction. And we have this in the dermal white adipose tissue. Until today, we have the subcutaneous adipose tissue, white adipose tissue, and the visceral white adipose tissue. Now we have the third, the dermal white adipose tissue. Here is when any aggressive produce the transformation, the adipocyte transition myofibroblast, the adipocyte go to myofibroblast, and produce fibrosis in the dermis. And this is very important because we know how to work over this alteration, use, for example, PRP, stem cell from the adipose tissue, exosomes, autologous exosomes, and carboxy therapy to recovery, because we can recover this adipose tissue to normal life there. So when the standard of care has been applied in the wound, we need to look what happened in 4 weeks. And it's the difference between chronic or not chronic. So when the wound continue after 4 weeks of treatment, it's a chronic wound. If the wound surface reduced 50% during 4 weeks, we are in the good treatment of this wound, and we continue the treatment during 12 weeks. If less than 50% the reduction of the treatment, we need to think about it to change the therapy, because this is not good result for the treatment of our patients. So ulcers in the extremity normally are chronic. Again, when they are no heal between 4 to 6 weeks and show no tendency to do so. And this is a great problem for our civilization, particularly the chronic wound because are in the chronic venous insufficient patients, and sometimes you mix arterial venous ulcers, and more problem is because sometimes happen in people who don't have the knowledge or the level to go to the hospital. For example, in some countries, in Latin America, for example, they are poor people, don't know what happened. They know they have a hole in the legs with exudate, and they don't go to the hospital. They sometimes you need to end with amputation of the legs for infection. 80% of all the lower leg ulcers are for venous. And in United States, the percentage of chronic wound is high and increasing all the years. Nowadays, venous ulcers is 1% of the United States population, or normally 4 million people. If we make a good treatment in our patients, 25 to 50% of the leg ulcers are not fully healed after 6 months. More than 30% of foot ulcers, or be careful, leg ulcers, foot ulcers, are not fully healed after 6 months of treatment. 70% of the leg ulcers are caused by venous disease, and 20% is caused by arterial insufficiency, like diabetic ulcers, but have another location in the legs. One is internal, another is external generally. And 85% of the foot ulcers are caused by peripheral neuropathy, often complicated with arterial disease. So we need to make a good diagnosis of our patients. With the risk factors for venous leg ulcers: advanced age, female sex, a family history of venous leg ulcers, white race, deep vein thrombosis or phlebitis, previous leg injury, chronic leg edema, a sedentary lifestyle, and prolonged standing. So you need to move and don't play a lot with the computer. Another risk factors for venous leg ulcer is bacterial contamination. This is a big problem for us and for the patient because they are poor wound healing and it's difficult to close the ulcers. And the other problem is the hypertension influence ulcer wound healing through a mechanism called mechanotransduction. Mechanotransduction is adapting physical force into biochemical signals and integrating these signals into cellular response. This happens with the pressure of the chronic venous insufficiency dermal fibroblasts activate. So this mechanotransduction inhibit the action of the transforming growth factor beta 1, and there are no stimulation over the fibroblasts. So if we have a bad conditions, our matrix or extracellular matrix, we don't have a wound closure. So we need to correct this system. I need our transforming ground factor beta 1 working well over the fibroblasts, and you have infections like bacteria biofilm, toxic cytokines in the ulcers. It's very important to make the antibiotic treatment to inhibit the ulcer wound to help to close the ulcers. So another problem that we have here, you have a lot of problems that you can see. But this, you imagine, yes, is all the problem that the cuff, the matrix, the inflammation, the edema leads that this area have hypoxia. And hypoxia leads to tissue necrosis. So, tissue necrosis, we have a solution, oxygen therapy. So we can treat chronic wounds with oxygen, and heal faster and more effectively. And we have new possibilities in wound care. And many people say, wait, we look what happened with the oxygen therapy in treatment the ulcers. So we know the hyperbaric oxygen treatment. 100% oxygen, pressure greater than atmospheric pressure, increasing the amount of dissolved oxygen in the blood. But we have a problem with this. We have two problems. If you give great elevate oxygen level, you always increase the production of the reactive oxygen species. You increase the oxidative stress. So you have more free radicals. You have more free radicals, in a tissue that this tissue don't have a good defense against the oxidative stress. So look good, but it's bad. It's not good, a large amount of oxygen. We will have a problem. And also, this production of the reactive molecules, the free radicals, don't allow to produce the reaction for superoxide dismutase. There are more hydroxyl radicals, and we have more inflammatory reaction in the wound healing, and more leukocytes and macrophages like M1 macrophage pro-inflammatory. Yes, oxygen is a good antibiotic as well, because hydroxylase require a high pressure of oxygen and also for the collagen synthesis to happen adequately. But we have another problem. When the cells want to make a physiology regulated, and we have in hypoxia, many cells in wound healing sub-process start to release vascular endothelial growth factors. And this produces his own vascularization around the area in the skin tissue. So if you have large amounts of oxygen, like hyperbaric, you don't have this reaction of vascular endothelial growth factor. That is very important because each cells produce his own microcirculation around the cells. This we saw this very useful when we make a lipografting, for example. Happen the same. So we need to look what can we do to find the concentration of the oxygen to don't produce free radicals and allow to produce for the cells the vascular endothelial growth factors. We know all the chronic wounds have a local oxygen deficiency, and it's important in this hypoxia, we need to know what is the amount of hypoxia to have the wound, because this allows to us know if we have a good reaction to our treatment. But remember, when you recover a good amount of oxygen, the cells regenerating in acceptable supply. So we have hypoxia and a chronic wound, and we need to compensate by replacing oxygen. But we need to replace oxygen, analogous to the natural supply of the skin. No grand amount that normal arrive to the skin, increasing the oxygen loading of the blood or from the exterior. So we need to try to recover the normal oxy conditions to help to the skin regeneration and healing the wound. How we know which is the amount of oxygen in the skin around the ulcers? Well, we use the transcutaneous oxygen device to allow to us measurement the amount of oxygen around the ulcers and allow to us follow the treatment and how change the hypoxia in the patient, and we know if the treatment is the right treatment for this patient. Also, we have another treatment that we talk in another moment. You have adipose cells, or you have mesenchymal stem cells, adipose-derived cell, nanofat, PRP, exosomes, autologous exosomes. For me, personality, I will tell you later which is the best treatment for the ulcers nowadays to working with the disease. The transcutaneous oximetry that I told you to use is explain the chronic limb ischemia and the ability of ulcers to heal. So when we make the treatment in the chronic venous insufficiency, we know what is the change if the oxygenation status. The normal range of the transcutaneous partial pressure of oxygen in the skin is greater than 55 milligrams of mercury. This is normal. All value less than 40 millimeters of mercury is critical, because below this number, you have ischemia. So we know if we have ischemia or hypoxia using the transcutaneous oxygen partial pressure to measure the tissue oxygen partial pressure. And this is, we allow to us look which is the provision of oxygen to the tissue cells, including the mitochondria. Also, we measure the transcutaneous oxygen near the wound, help us look what happened with the perfusion change in the skin. There are many studies about this. Many people, when use this kind of device, put in the device the tip of the device for centigrades, so there are no change in the skin. And again, is the same. This device allows to you in the chronic venous insufficiency marker of oxygenation status. Again, normally more than 55. When it's 40 to less, you have ischemia. And you have chronic wounds regarding oxygenation, and you need to work to give to this wound more oxygenation. Carboxy therapy, I use carboxy therapy since 35 years, but until 8 years ago, use injectable CO2. I have also papers. You can find papers from me in PubMed about use carboxy therapy injectable in patients with diabetic ulcers. There are patient diabetic ulcer ready for amputations in Argelia, and these 40 patients after the treatment with carboxy therapy during 1 year, all recovery the wounds, and there are no amputation. So surprise to me when I look, there are carboxy therapy transdermal. It's a long history, but really you can find my papers in PubMed. We know it's the same, exactly the same, transdermal or injectable, but carboxy therapy transdermal is more easy and non-painful for the patient. The gaseous state to the subcutaneous injection of transdermal application using 2 gels to producing real CO2. The CO2 diffuse very quickly through the cutaneous and muscular microcirculation, increase the microcirculatory vasodilation, improving blood flow and working over the arteriolar smooth muscle cells. And also promote Bohr effect. It's a crucial physiologic process in the body's oxygen transport system. This is Bohr effect. The Bohr effect is referred to decrease in hemoglobin affinity to oxygen due to increased CO2. So where you place in any area of the body CO2, the hemoglobin who come in the blood with 2 oxygens, when look, there are one area full of CO2, release the oxygen and take the CO2 because hemoglobin have 20 times more affinity for CO2 than oxygen. So hemoglobin take the CO2 and go to CO2 to the lungs and leave in this area oxygen. So it's paradoxical where you inject CO2, you increase the partial pressure of oxygen. And this is the Bohr effect and move the curve to the right. So it's the same that I explained to you. And this, of course, you have more oxygen, more hemoglobin, more oxygen for the tissue. So you increase all the therapeutic action and you increase the flexibility and decrease the hardness of the collagen fibers, reduction the divalent calcium ion, this is vasodilation, decrease tonus artery and capillaries with vasodilation, increase the blood flow in the application site, so more microcirculation, improve the tissue drainage of the lymphatic circulation, the microcirculation in the precollectors, the lymphatic precollector, increase the work of the lymphatic precollectors to make the more the lymphatic circulation, release local growth factor, you increase angiogenesis, you have more lipolysis and skin regeneration, and you increase the microvascular relation. So all of this happen with the carboxy therapy, and here you have all the reference if you wish. So the Bohr effect describes how hemoglobin oxygen affinity change in response to the CO2 and pH levels. So in tissue, we have high CO2, lower pH, oxygen release as hemoglobin binds to this molecule of the CO2, and more oxygen in the in the area of the tissue. So the Bohr effect explains the increased CO2 in the blood to go to the lungs and explain why curve of the Bohr effect move to the right to the pH more acid. So when the CO2 arrives to the lung, there are another effect, it Haldane effect to liberation the CO2 through our lung, and sometimes some CO2 go to the urine as well. I move this, and we use transdermal carboxy therapy. It's a combination of two gels, 2 pack of gels. One have magnesium carbonate and other is gluconolactone, part of the formula. Really, when I know this product, I say 8 years ago, was in contact with a cousin to working in the big company in Israel about the laboratory, very, very important, and asked to her, what do you have if you combine this and this? And she said, CO2, easy. So, well, we have really CO2. They are activate, and when you mix and activate, you have 45 minutes to use because this mix release CO2 only during 45 minutes. You apply topically. This is the secret how you make the combination. And there are many studies from Sakai, for example, talk about the beneficial and increase the blood flow on microcirculation with laser Doppler. Also, our work with video capillaroscopy published in PubMed, and you look how improved the microcirculation in this after the application of CO2. The study for Amano Iga to demonstrate the combination help accelerate wound healing, but upregulation, remember, vascular endothelial gram-forming ground factor beta? Well, here is the result when you make this. So, and the application of this gel also accelerate the wound healing, improving hypoxia, increase angiogenesis, and reducing the expression of inflammatory cytokines. So we make this study and publish this study, and I say really was a flip coin because we take a large amount of patients with ulcers, varicose ulcers, in a city in Argentina called Cordoba. Patients that no good economic situation, hospital, are patients who don't have any answer to the primary treatment that you say, I say to you before, the 4 weeks or 6 weeks. So this is the study was conducted where in Cordoba. If you don't know Argentina, if you don't know Cordoba, visit Cordoba. Is amazing place to visit in Argentina. Very nice, very nice. Lakes, mountains, very nice. It's in the middle of the country. So 40 patients was selected with severe varicose ulcers. This was one of the premise. And they have the same primary ulcer treatment with not responding. 4 weeks of the primary treatment and no happen nothing with the wound healing. So we add to this patient transdermal CO2. Many of them we make the application in the hospital. Some of them with the family help to make the process in her or his home. Remember, sometimes the cultural level of these people is not so higher, so we need somebody to help to them to make the mix and the application, and we need to control. We prefer sometimes to come to hospital to make the application, but the problem to come to hospital, you need to take a bus and come to hospital. It's a problem. So we use this in 40 patients. We applicate the study because the problem of the movement of the people exactly is twice a week. We give the money to take the bus also. For 4 weeks, they continue with the primary treatment is a medication, elastocompression stockings, and some cream. The no cream is a topical treatment of the ulcers with antiseptic. That's it. And some of them take some antibiotics. And then we start to work with the application of the CO2 transdermal. And you can see here the 0 weeks, 4 weeks, 6 weeks. This blue point is where we measure the transcutaneous partial oxygen with the device. And all the patients clean their varicose ulcer with a sterile saline solution. We give the sterile saline solution, cover the ulcer with a sterile dressing, and then we change twice daily. So we take the patient, we take the photos, and look what happened. Also, we make what happened with arterial. So we make arterial echo Dopplers, and look what happened with the arterial microcirculation after the application of the gel. And this is interesting because we make this, we take before the application of the first application of the CO2 gel in the patients and after first sessions, immediately. And in all the case, we look an increase between 3 and 5% in the stroke flow at the microcirculatory level. And this is very good because we talk about the future of the result of the treatment. We improve the arterial microcirculatory level immediately. Clinical manifestation, diameter, length, granulation. We look the size of the wound, the length and width, exudate, granulation is all that we evaluate in these patients. And we use the scorer of the wound also, called the bed scoring. Is 0 is closed, 1 is epithelial tissue, 2 is granulation tissue, pink, 3rd is slug yellow or white tissue, and 4 is necrotic tissue, is a scar. Also, we evaluate the transcutaneous oxygen through the transcutaneous oximetry, simple, reliable, non-invasive technique to allow to us know what happened with the perfusion and oxygenation. The patient was in supine positions, and we measured the peri-ulcer skin 1 centimeter proximal to the upper margin of the ulcer, that you will see here. And we use the sensor, especially, and you have more reference. So the device is attached, the sensor, to the adhesive ring, and we clean the skin with a liquid, and also disinfectant. The transducer is heated to 44 centigrades, and we look what say about the transcutaneous partial pressure of oxygen. Normally, I told you is better than 55 millimeters of mercury. So you can see another patient here. Here is the measure, the evolution. You can see how close. And we look decrease the wound size, reduction in the amount of exudate, and improve wound score. And look what happened with the oxygen diffuse according with this pressure gradient from the capillaries looped through the avascular epidermis. Remember, this coming from the normal skin to the ulcers, and also when you have hypoxia, the same cells produce vascular endothelial growth factors to produce more microcirculation. So here are some patients for you. So this is patient 1. Some examples. You can see the evolution. It's very clear. Start with 14 millimeters of mercury. And after 4 weeks, we have 36 millimeters of mercury. 36. So we need to still continue to work to find the 555. And the bed scoring go 3 to 2. You can see the difference. This is dramatic patient, and you can see 0 weeks. We control this patient after 8 weeks. I will tell you something. We continue to control this patient after the study, and these ulcers, as the doctor told to me, is all closed. And this was a very, very bad patient. But look, the TC 12, 20, 41 after 4 weeks. We are almost done, Lauren, almost done.
It's so impressive. It's amazing. Keep going. Just want to be respectful of your time.
Another patient, 6 weeks, and you can see again with the treatment how it's closed, how improved the wound ulcer bed, the 3-to-1 reduction, the exudate, and look the oxygen how increased. Remember, it's only 8 sessions, 2 sessions a week. This patient is dramatical, but look after 6 weeks, and we are close to 41 millimeters of mercury, and we go with the ulcer bed scoring 4 to 1, 6 weeks. Another patient is more smaller. These ulcers is 4 weeks, go to 44 millimeters after 4 weeks. And the scoring go 3 to 0. All the patients have elastocompression therapy, sterile wound dressings, and local therapy like collagenase creams. All they use a medication called Diosmin in Argentina. And this is the treatment. They don't have any change. So this is when I apply the transdermal CO2 gel to these patients, in patients who have a chronic venous insufficiency and post-phlebitic syndromes. And some of them have osteoarthritis, of overweight. It normally happens with this kind of patients. We apply the CO2 Pro gel, and all patients we instructed to working with them that I told you, or the family members help to us sometimes to improve the result after. And we look something is enhance the skin quality, recovering the condition of the surrounding skin, diminish exudate, and improve granulation. All the bad situation to our before, we can change when we add the transdermal carboxy therapy. In all the case, we use arterial Doppler in all the patients, arterial echo Doppler, and look what is the change and improve the microcirculation and SAYO, and we use the peribund TCPO, P-oxygen, and increase also. Yes, this study have a limitation. The limitation is only 8 applications with CO2 Pro in this, but it's impossible for this patient to, the management of the patient to go and back to the hospital. But this is the negative. The positive of all this treatment is yesterday I talked with a doctor in Cordoba to continue the follow-up of these patients. And we are very friends. We share the same sport. So we talk about rugby. Rugby is our sport. And you know, Argentina is very good team of rugby. We have very good soccer, football, and very rugby, good. I say, hey, how was the patient? What happened with the patient? 40 patients. What happened? He said, you know why? 80% of them, the ulcers are closed, and they don't come to the office again because they say they don't need it.
Wow.
They say that they continue with the elastocompression stockings, with the diosmin, and more of them use more CO2 gel during few months because we have more supply they give to them. All of them, there are no, the first to say all the people when start to use CO2 gel don't have pain. The first to disappear was the pain. And the pain is go to the hands with the hypoxia and the recovery of the microcirculation. So this is what the good of this, I talked yesterday, say, okay, if anybody, because one of the secret, if we need to recovery the skin from the bottom to the top, not only the top and then appear again the ulcers. We need to recover the skin from the bottom to the top. This is why it's important the vascular endothelial growth factor, it's important the PO2, it's important all the action of the to produce carboxy therapy in all these patients. If you ask to me, which is the future from the ulcers, the future is CO2 transdermal. It's possible the patient use all the days, is better and more quickly results. And the injectable autologous exosomes from PRP. And this we make a result for these patients. And we'll be very happy with elastocompression stocking as well for the perfusion and all the we know to use in our patient to recovery this kind of legs in our patient and this pathology. These men, you know, I don't know, you know, these men say quick and easy is not an indication. Varicose ulcers need a good indications to work quick and easy, but with good medical indication for the recovery of the patients. These patients say many things. When you close the ulcers, you stop the pain, and the patient can walk again. It's very important. So hope these presentations help to you. And if you want to make any question, I am here. Thank you very
No,
much.
thank you very much, Dr. Liebeschoff. I know this was all packed with a lot of information. The recording will be available for all of you to rewatch or to share. I'm going to include, just because I want to be respectful of Dr. Liebeschoff's time and everybody else's time. So I know we did get a couple of questions and had some that were submitted prior to the webinar live.